Hello, I'm Matthew Weinstock with Hospitals and Health Networks. Rural hospitals and federally qualified health centers have not always lived in harmony. While servicing similar if not the same markets, competitive forces and regulations can put those two organizations on a collision course. But as healthcare moves toward a more integrated and collaborative environment, some of those walls are coming down. I'm joined now by Darrold Bertsch, CEO of Sakakawea Medical Center in Hazen, North Dakota, to talk about how rural hospitals and FQHCs can come together. Darrold, thanks for being with me.
Thank you.
So can you give me a little bit of an overview of your market? What are the demographics like, the critical access hospital and the FQHC, what kind of market you're serving?
We're a small critical access hospital licensed for 25 beds located in central North Dakota. We're on the edge of all of the activity with the Bakken in western North Dakota, but we're far enough away that we don't have all of the influence and challenges that are present in the heart of that Bakken activity. And we're about 75 miles from Bismarck, North Dakota, the capital.
And so historically, what's been the relationship between the hospital and the FQHC?
Well, I think if we look historically at greater than 3 years ago, there was a competitive relationship in place. As is the case with many rural communities, there's competition for the resources that are there, the staffing that's necessary for the patients that we want to provide services to. So I think it was a competitive relationship that was in place between the two organizations. Now, since that point in time, we've been able to develop a collaborative spirit and a collaborative leadership in place between the organizations.
Right, and part of that is you took over as CEO of now both organizations in March of 2011, right? And so how did that come about?
The health center and their former CEO decided that it was time for that relationship to end. And at that time, the health center approached the hospital board about the potential of us providing some assistance on an interim basis to provide some guidance and leadership of that health center. And so the hospital board at that particular point in time then agreed, and that's when the collaborative leadership relationship started, again, as an interim.
And then you obviously had to approach HRSA to get some approval for this. Mm-hmm. What was that like? Well,
HRSA was very open-minded up front to allow an interim relationship to be established between the two organizations. They were aware, too, that there had been some competition between the organizations, and we're glad to see that we were working together. And they supported an interim-type relationship so that we could have that shared leadership and work on things.
When you talk about collaboration, though, what were some of the first areas that you looked at that you said, boy, the hospital and the FQHC, we could really work together in some of these areas to improve population health?
I think one of the first things that we did was we looked at ancillary services that were being provided and the primary care services that were being provided by both organizations.
And how do you decide where those services are going to be situated then in that kind of circumstance?
Well, you look at patient convenience, and then you look at the reimbursement from the programs for those services that are provided. Again, keeping the patient basically to the forefront, but also making sure that it was financially sound decision to make the changes that we did.
The hospital and the health center are not united in financial structure, correct?
That's correct. They are separate 501c3 corporations. We get to go to 2 board meetings, one right after the other at the end of the month, but they're separate organizations, have separate boards. But what we have been able to do, and this has been very important in this entire collaborative relationship, is we share board members. We have 2 health center board members that serve on the hospital board and 2 hospital board members that serve on the health center board. So there's greater transparency and better transparency than allowing just the CEO to be that voice between the 2 organizations. It's actually the board members communicating as well, holding the CEO accountable for what's going on to make sure it's the same message. The other thing that we've really done that I think has helped us immensely is we've done a collaborative community health needs assessment that has not only included the FQHC and the critical access hospital, but it has also included public health, the local nursing home, and the local ambulance service as well. And now, together, we're developing a community and collaborative strategic plan. Because all too often, entities might look individually at what are their needs and what is their strategic plan. So now we're developing a collaborative strategic plan, but then each entity will have specific responsibilities within that entire structure or that entire strategic plan. But we're all sitting together at the table talking about this and what are truly the community needs and how are we going to address community needs. And for example, I'll just give one illustration of one of the areas or the goals that we have in our strategic plan, and that is population health. How can we improve that? The hospital has started a robust wellness program that we not only have put into place for our staff and our families, but also the Coal Country Community Health Center as well. And then we've reached out to Knife River Care Center, which is the local nursing home, and we've expanded that wellness program to all of those entities. The other thing that we're doing is the FQHC, Coal Country, has a very robust patient-centered medical home that's in place. So we're going to use that expertise to develop that at the hospital side too. And what we hope to develop is a patient-centered medical neighborhood.
And so as you work through some of the issues you're working on with the health center and the other parts of the community, what do you think the message is to other rural hospitals, other critical access hospitals that may not have the same structure you guys have, but have a FQHC in their community and are trying to figure out ways to get past some of the historic relationships that they've had?
It starts with leadership and the board. If there's some way of integrating that and creating that and establishing that trust, that's an important first step. And you got to have providers that are on board as well too. We all see it too often in smaller communities where the health center might be the only employer of physicians and the hospital doesn't employ any physicians. There has to be a collaborative spirit. How is that emergency room going to get covered, et cetera, et cetera, et cetera. But if you take it one bite at a time, I think there can be small successes that can lead to bigger wins.
I appreciate your time today.
Thank you. I appreciate the opportunity.
And I'm Matthew Weinstock for H&HN. Thanks for tuning in.